It's a real pleasure to be here today to talk to you all about evidence for the role of the gut in IgA nephropathy, how there's been some exciting developments in our understanding between the links between the gut and the kidney in this condition, and how this has really paved the way towards new therapeutic strategies in this condition. So why are we studying the gut in what is primarily a kidney disease, IgA nephropathy? Well, I think it's good to go back to the beginning, in that IgA nephropathy is defined by the deposition of IgA within the glomeruli. And that IgA has now been really well characterized through a number of careful studies. And we know several characteristics of that IgA, which are quite particular for this condition, in that it's IgA1 in isotype, and that differs from the other isotype in humans, IgA2, in that IgA1 has an extended hinge region, which can be variably glycosylated by addition of O-glycan sugars. That the IgA is polymeric in nature, and by that I mean that it's more than one IgA molecule joined together by J or joining chain. And then when we go back to that hinge region, we know that the IgA that's deposited lacks galactose residues within that. And that seems to be a particular feature of IgA nephropathy. And this form of IgA is also increased in the serum of patients with IgA nephropathy. So just to look at that hinge region in a bit more detail now, we can see those terminal galactose residues called GAL in this diagram here, the kind of purple color. And in IgA nephropathy, the IgA that's deposited lacks these galactose residues, as you can see here. And so not only do we know that this form of IgA is deposited and is found at increased levels in patients with IgA nephropathy, it also correlates with prognosis. So increased levels lead to a worse prognosis from IgA nephropathy. And there's several lines of experimental data now showing this form of IgA is particularly pathogenic. So this form of IgA can stimulate mesangial cells to proliferate and release cytokines. And it can also activate the complement pathways, which we know is a really important driver for inflammation and damage in IgA nephropathy. There's also very good evidence now that this form of IgA can act as an autoantigen, driving autoantibody formation against this, contributing to the immune complexes that then deposit in the kidneys in IgA nephropathy. So if we go back to the start then, the IgA that's deposited has these characteristics. It's IgA1 in isotype, it's polymeric, and it has low galactose content from its hinge region. And then if we think about where IgA is produced in the body, most IgA is produced at mucosal sites where it plays a really important role in host defense against bacteria. And then out of these mucosal sites, the gut is the primary site where IgA is produced in the body. IgA can also be produced in the bone marrow by plasma cells, and this is the main form of IgA that's found within the systemic circulation. But when we examine these two types of IgA in a bit more detail, the IgA that comes from the mucosal system is polymeric and has low galactose content within its hinge region, so really resembling the IgA that's deposited in the kidneys in IgA nephropathy. The IgA that's the majority in the circulation in healthy subjects produced by the bone marrow is monomeric and has high galactose content within its hinge region, so quite different to what we see in the kidneys. So that's really led us to believe that the IgA in IgA nephropathy that's deposited is coming from a mucosal source. Now, this is the multi-hit hypothesis of IgA nephropathy that is very well established now. And what we can see is that there's an increased amount of poorly galactosylated IgA1 in the serum, as we've discussed. This is mucosal type. And then within the circulation, there's this autoantibody formation against this with anti-IgA1, IgG, and IgA antibodies that then drive immune complex formation that then deposit within the kidneys, driving this process of inflammation, injury, and damage. So changing tack slightly, we've known for some time now, and this is work that's been done over several years, that in patients with IgA nephropathy, there are raised IgA antibodies against several antigens that are normally seen at the mucosal surfaces of the gut. So there are raised levels of IgA antibodies against Helicobacter pylori, against dietary antigens, and against all vaccinations as well. In Leicester, the group looked into this in more detail by examining responses to Helicobacter pylori infection. And as you all know, H. pylori lives within the gastric mucosa, and it plays a key role in causing peptic ulcer disease. And what they did in this study was identify patients with active H. pylori infection by doing urea breath tests and look at the IgA responses against H. pylori. And what they found was that in IgA nephropathy patients, there were far higher levels of IgA against H. pylori compared to healthy subjects who were equally infected. And this suggests that there's an exaggerated antibody response against a mucosal antigen. When they looked at the form of IgA that was produced, the majority of that IgA was polymeric, with no difference between patients with IgA nephropathy and healthy subjects. But you've got to remember that patients with IgA nephropathy were just making far more of this IgA compared to healthy subjects. The group then went in and looked into this in more detail. So they used an assay called leptin binding. Leptin binding is a way of measuring galactose content within the IgA1 hinge region. So as you can see here in the diagram, this is undergalactosylated IgA1, and it will have raised levels of leptin binding because the leptins can bind to those exposed epitopes. And again, as you'd expect, with IgA nephropathy patients having higher levels of undergalactosylated IgA1 within the serum, that leptin binding levels were high in IgA nephropathy patients compared to healthy subjects. The group then went on to look at responses towards mucosal or systemic antigens in IgA nephropathy patients. And for the systemic antigen, they looked at tetanus toxoid. So tetanus toxoid is something that most of us have been vaccinated with. It's injected through the skin, so it never sees the mucosal immune system or mucosal surfaces. And what they found in this study was that responses against tetanus toxoid in the IgA system showed low levels of leptin binding and therefore normal or high galactose content IgA, as you'd expect within the circulation. But again, against our mucosal antigen, the form of IgA that was produced had high leptin binding, so low levels of galactose or undergalactosylated IgA1. So putting this all together then, in the mucosal immune system, against a mucosal antigen, we have production of polymeric IgA, which is undergalactosylated and therefore has high leptin binding. But the difference in IgA nephropathy patients is just that there's far more of this IgA1 being produced. And this has led to the theory that there's exaggerated IgA responses that are kind of inundating the kidney with immune complexes that drive IgA nephropathy. So going back to our table then, if we look at antibody responses against a mucosal antigen, these seem to be exaggerated in patients with IgA nephropathy compared to healthy subjects. So we've known there's a link between the mucosal immune system and IgA nephropathy ever since this disease was first described in the late 60s and early 70s. And I'm sure all of you have patients like this in your clinic who quite classically have a mucosal infection followed 24 to 48 hours by visible hematuria and a nephritis. And so the links between the two have been further examined. So Professor Feely, in one of these seminal research studies, looked at the IgA system in IgA nephropathy in states of nephritis. So what they did was look at patients in clinical quiescence, which they called a remission, or a relapse of their nephritis during these flare-ups. And what they found was that there were subtle dysregulations of circulating T cells and B cells. But what I want you to concentrate on the right-hand side is the different profiles of IgA that were produced during these acute infections and flares. So on the left side, in number 1, in patient number 1, they've divided total IgA into polymeric, dimeric, and monomeric fractions, as you can see in the initials at the top. And then in states of flare-ups or the nephritis, in the dotted lines, you can see that far more of the polymeric and dimeric IgA is being produced in response to that. And Jan Novak's group subsequently have taken this further and applied this form of IgA onto mesangial cells. And through these careful studies, what they've found is on the graph on the left in the solid dots, this form of IgA was able to really trigger mesangial cell proliferation and stimulation and cytokine release more than the IgA that was isolated during states of clinical quiescence in the hollow dots. So this is really linking together states of mucosal infection and stimulation, the mucosal IgA response to that, and mesangial cell proliferation and cytokine release and the nephritis that we're seeing. Another strong line of evidence that really implies that the mucosal immune system plays an important role in IgA nephropathy is secretory IgA. So secretory IgA is formed when dimeric IgA binds to the polymeric IgA receptor, and this only happens at mucosal epithelial sites. This then facilitates the transport of that IgA into the lumen, and it takes with it part of the polymeric IgA receptor called the secretory component. And this component gives that IgA resistance to proteolytic cleavage. And through studies in IgA nephropathy patients, we know that the level of secretory IgA is increased in IgA nephropathy patients, and also elevated levels are associated with worse histological features in IgA nephropathy. We know that that secretory IgA can also be isolated from those glomerular deposits in IgA nephropathy. And we also know that after mucosal immunization and stimulation, that secretory IgA is released as part of that polymeric IgA. So going back to our table now, secretory IgA can, as I said before, can only be produced at mucosal surfaces and can be found within those glomerular deposits. And now we've got a really strong picture showing that the mucosal IgA is IgA immune system is really driving the source of that IgA in IgA nephropathy. So I just really wanted to focus now onto the mucosal associated lymphoid tissue. As I said before, the gut is the main site production of IgA in the body. And this mucosal associated lymphoid tissue is focused in specialized collections called the Peyer's patches. And these are most concentrated in the terminal ileum. And within this tissue, there's a complex set of processes by which naive cells are class switched into IgA producing cells. And so if we can understand the factors that regulate this process, then we can start to think about how we might be able to reduce that mucosal IgA production that's coming from these sites and think about therapeutic targets. And so one of the strongest lines of evidence that links together the gut and IgA nephropathy comes from genetic studies. This is the meta-GWAS that was published by Christoph Kirilluk and Ali Gharavi, led by Columbia, and it was a very large collaboration. And what they did was take a series of genome-wide association studies and look at risk alleles for the risk of developing IgA nephropathy. And then they mapped these against biological processes known to happen in the human body. And what they found was that the network that really stood out was the intestinal immune network for IgA production. Another really fascinating piece of work that came out from this study was that they found that the genetic risk seemed to correlate with pathogen diversity. Now, we've known for some time that the prevalence of IgA nephropathy increases as you go from the west to the east, and it's especially prevalent in East Asia and Southeast Asia. And what this study is suggesting is that the genetic risk also increases as you, in accordance to that prevalence, and that pathogen diversity matches that. So it suggests that populations within these areas have evolved with mucosal immune systems that are particularly adept at dealing with the local pathogens. And what's really interesting is that also correlated with helminth diversity, which are gut parasites. But perhaps the genetic trade-off to this has been that these populations have developed mucosal immune systems that are particularly prone to spilling out this mucosal type of IgA into the circulation, therefore increasing the risk of IgA nephropathy. So it's an interesting hypothesis, and a lot of work is going into this at the moment. We know that this process of class switching of naive B cells into IgA producing cells happens under the influence of T cell dependent and independent means. And two of the key cytokines in driving this are BAFF and APRIL. So BAFF and APRIL are both increased in patients with IgA nephropathy, and they work via a series of B cell surface receptors to drive that process of class switch recombination, B cell survival and proliferation. So this is interesting work that came out now some time ago, examining a BAFF overexpressing transgenic mouse. And what they found when they examined these mice was that this overexpression of BAFF induced a hyper-IgA syndrome, so very elevated levels of IgA. But this IgA was derived from the intestinal lamina propria. And then when they looked at the kidneys of these mice, they developed an IgA nephropathy-like disease. There's also evidence now to show that gut bacteria can influence the production of IgA. So gut bacteria can do this via pattern recognition receptors on dendritic cells, and then dendritic cells communicate with naive B cells to cause class switching and IgA production. And we know this process is important because going back to the BAFF transgenic mouse, when they reared these mice in germ-free environments so that they were not colonized by gut bacteria, the IgA nephropathy could not develop. It's only when they reintroduced these gut bacteria was when the disease could occur. So here we have a series of studies linking together the gut microbiome, BAFF expression, IgA production by the gut, and IgA nephropathy. And we think that toll-like receptors are important in communicating that process between the host microbiome and gut bacteria to the mucosal immune system. Now, toll-like receptors are expressed by a number of cells within the mucosal immune system, and they act as pattern recognition receptors, recognizing bacterial motifs. And there is now experimental data to show that signaling through these can influence not only the amount of IgA that's being produced, but also IgA galactosylation as well. And these processes are under the influence of BAFF and APRIL. So there's a lot of interest in the host microbiome, and in IgA nephropathy, there is early evidence to show that the host microbiome in patients with progressive IgA nephropathy compared to non-progressive and healthy subjects may be subtly different. Now, these are early studies, cross-sectional in nature with relatively small sample sizes. But again, this is a fascinating insight into how this subtle changes in the gut microbiome may play a role. So as we go from west to east, perhaps some of this difference in the prevalence of IgA nephropathy could be due to genetic predisposition, but also could be due to environmental factors such as gut bacteria, the host microbiome, and tipping the balance towards a mucosal immune system that is producing a hyperreactive mucosal immune system, producing this mucosal pathogenic IgA into the circulation, increasing the risk of developing IgA nephropathy. I'm just going to touch on IgG very briefly. There are some studies now that are suggesting that the microbiome can influence IgG production. We know that IgG plays a very critical role in the formation of immune complexes in IgA nephropathy. We don't know at the moment whether this process is important, and there are many studies ongoing to look into this. And finally, I'm going to touch on this study by Renato Monteiro's group from Paris. So they have developed a mouse model of IgA nephropathy using a knock-in of human IgA into this that develops IgA nephropathy spontaneously. And what they showed in this study is that if you ablate the gut microbiome by treating with broad-spectrum antibiotics, then the IgA nephropathy in these mice does not develop. Clearly, that's not an approach that we can take in humans, but there is now a lot of focus looking at whether we can target the gut, especially the gut microbiome, to try and influence the natural history of this disease. So I hope I've shown you that there are subtle interactions between the gut microbiome and the mucosal immune system. And we believe now in IgA nephropathy that this balance has become slightly dysregulated, leading to an immune system that is particularly prone to spilling out this pathogenic mucosal IgA1 into the circulation. And here we go back to our multi-hit hypothesis, and we can see that dysregulations within this interaction can lead to an increased amount of circulating poorly galactosylated IgA1, either directly or perhaps by mishoming of IgA-primed B cells into systemic sites, such as the bone marrow, to produce this increased amount of IgA1 within the circulation. Therefore, then causing these downstream effects of immune complex formation and glomerular disease. And as a nephrologist and a clinical researcher, I'm really interested in how we can target the gut upstream to try and prevent all these downstream effects from happening. So I hope over the past 20 minutes, I've managed to convince you and shown you several lines of evidence that IgA nephropathy is a disease that originates from a dysregulation of the mucosal immune system, and it is mucosal IgA in origin that is deposited within the kidneys. And I think if we can try and focus our efforts on understanding these processes better, then we can intervene at this level within the gut to try and influence the course of this disease and improve outcomes for our patients. So thanks very much for your attention. And now I'm going to pass it back to Dr. Lafayette. He's going to talk about proteinuria and eGFR as endpoints and how they translate into patient outcomes.
Thank you very much, Chike, for that wonderful talk. And we'll now move on to exploring proteinuria and estimated GFR as endpoints and how they translate into meaningful patient outcomes. So when we think about IgA nephropathy in 2022, there's still many unmet needs. Again, this is the most common form of primary glomerular disease, but yet it's often detected late, maybe beyond when patients can benefit from treatment and already have chronic kidney disease or approaching dialysis. There's limited approaches per clinical practice and per our KDIGO guidelines in terms of getting to adequate blood pressure control, utilizing optimal doses of RAS inhibitors, and then it's uncertain what to do. Do we get patients into clinical trials? Do we utilize steroids despite known risks? Do we use other treatments based on the race of the patient, such as tonsillectomy, or rare cases to use mycophenolate? And to answer these questions, we really must have reliable outcomes to judge the relative safety, efficacy, and even tolerability of newer interventions, which are certainly on their way. Our ultimate goal is preservation of kidney function in a safe and well-tolerated manner. And maybe we can learn how to judge treatments based on what the prognosis is in IgA nephropathy. we know there's several features that determine outcomes, such as gender, age, blood pressure, proteinuria, hematuria, kidney function, and biopsy findings, such as the proliferation, sclerosis, interstitial fibrosis in the Oxford-Messi score. And perhaps there's other biomarkers. Those bolded in the slides are those that we've really learned to rely on in terms of prognosticating how patients will do. And perhaps the most strong factor that we utilize in determining how patients will do is the timed average proteinuria. Here you can see several diseases, IgA nephropathy, FSGS, and membranous nephropathy, where proteinuria predicts outcomes in each of them. But in IgA nephropathy in the dark blue, that transition to a worse prognosis really occurs beyond 0.5 grams per day and sits firmly at levels above 1 gram of proteinuria per day. And evidence has arisen largely from the Toronto GN group that the proteinuria over time is strongly linked to outcome. And here through the different color codes in this slide, you can see from going from very mild proteinuria to fairly severe proteinuria greater than 3 grams per day in IgA nephropathy, that there's this graded outcome getting worse and worse as proteinuria gets more severe. And taking all of these factors together, the International IgA Nephropathy Risk Prediction Model was created and subsequently well validated that if you use multiple variables, including estimated GFR at the time of biopsy, blood pressure, urine protein, patient characteristics such as age and race, their use of medications such as ACE inhibitors or exposure to steroids, and their pathology features, you can make a decent prediction from biopsy of how their kidney function will fare over the next 5 years. And what we really want to know is classic outcomes. We want to have patients, again, survive without kidney failure, without advanced chronic kidney disease. And in rare enough studies in IgA nephropathy, patients have been followed to a classic outcome, that is reaching dialysis or having a 50% reduction in kidney function. And this slide just shows an example from the TESAR study of the Valiga registry that looked to see whether immunosuppression compared just to conventional therapy preserved kidney function. And at least in this observational study, they use these classical outcomes of renal survival to really determine whether or not the intervention was reasonable. And when we look at epidemiologic data, evaluating those classic outcomes and other markers that might predict those classical outcomes, we hope that we have an effective shortcut, because epidemiologic data do indicate a significant association between changes in proteinuria and the kidney outcome. So in these observational studies, there's been consistent association between the severity and duration of proteinuria and that kidney function loss. The timed average proteinuria was also observed to be the most important risk factor for progression to end-stage kidney disease, and sustained proteinuria, typically at that range greater than 1 gram per day, has been strongly associated with poor kidney outcomes. And so statistically, when you look at the relationship between the treatment effect on proteinuria and the treatment effect on hard clinical outcomes of kidney failure or a 50% loss in kidney function, that relationship becomes very statistically significant with a predictable line that develops. And there is some variability study to study, but the relationship holds up and appears to be very strong. And this is true in the overall CKD population, where changes in proteinuria predict ultimate strong kidney endpoints, such as loss of kidney function and need for dialysis or transplant. And on the right-hand side here, again, in IgA nephropathy, this was also true, where a predictable slope can be made between the relationship between a treatment's effect on proteinuria and the outcome of kidney loss. Therefore, it was thought that proteinuria could actually be used as a basis for accelerated approval of new therapies for IgA nephropathy because of this strong relationship between a treatment's effect on proteinuria and the treatment's effect on clinical outcome. And indeed, after multiple special groups got together and the FDA in the United States was involved, collectively it was concluded that analysis of the data overall support the use of proteinuria reduction as a surrogate endpoint for a treatment's effect on progression to end-stage kidney disease, and that the FDA would evaluate this and utilize this as a surrogate endpoint for accelerated approval. Now, is that the be-all and end-all? We'll see, because now we have seen FDA-approved drugs for reduction in proteinuria in context of other changes, and we'll see how that relates to endpoints. But for an independent contribution to these important outcomes, we've also known that GFR itself relates to outcomes. And so shorter-term changes in GFR may also be utilized in order to predict progression in patients with IgA nephropathy. Here's one study by Lee and colleagues showing that when you look at a multivariate approach to progression and look at those factors that significantly impacted your progression, some of the pathologic features still were there, such as T-score, the baseline GFR was there, but then the most strong factor, was the estimated GFR slope per year. So really changing kidney function early is going to predict changing kidney function throughout the study and through patients' lifetimes most strongly. And in fact, this has also been shown in general for chronic kidney disease, that treatment's effects on GFR slope is a powerful, predictable way to predict longer-term outcomes of dialysis, transplant, or 40 or 50% reduction in kidney function throughout chronic kidney disease randomized controlled trials. And therefore, we also looked to see if this was true in IgA nephropathy. And again, no surprises. There's a very tight relationship between a treatment effect on even the first year eGFR slope and ultimately that hard clinical outcome of kidney loss. And this relationship is seen in a linear fashion, utilizing all randomized controlled trials for IgA nephropathy. And in fact, if a similar analysis is done of these randomized controlled trials as a multivariate analysis looking at eGFR change at 1 year as a predictor, it very nicely survives a multivariate model, as you can see, with a very low p-value and a strong relationship, again suggesting that as a biomarker or as a treatment effect, 1 year eGFR slope may be a very valuable predictor of treatment effect in terms of ultimate outcome. So, of course, there's other things to consider. Publications have also focused on the patient experience. When we come up with treatments for our patients to improve their kidney outcomes, we also wanted to improve their quality of life. So here's one example of a study looking at identifying outcomes important to patients with glomerular disease and to their caregivers, and looked at what outcomes matter to patients in terms of undergoing treatment. And as you can see, this study was done multinational, a good number of patients with questionnaires, and says, indeed, they want their kidney function to be improved, they want to survive, they want to avoid dialysis, but they're also very keen to feel healthy, to be able to participate fully in their life, to avoid fatigue, to avoid pain, to not have an impact on their family lifestyle, to have an ability to work. So when we come up with new medications, it's important we consider the patient reported outcomes as well as simply our measurements of kidney function. So for this talk, I wanted to point out that data certainly support the use of proteinuria reduction as a surrogate endpoint in IgA nephropathy, and that it's really critical that studies of IgA benefit from validated outcomes, ultimately kidney survival, sustenance of GFR, that the GFR slope could prove to be even more impactful than proteinuria reduction in terms of predicting outcomes of interest and maybe saving money and time in studies to really understand what treatments really have legs versus don't. But right now, it's not entirely certain how many years are needed. Is the 1-year GFR slope adequate? It definitely looks to be from these observational studies. Again, do other biomarkers, such as the biopsy outcomes, such as changes in galactose-deficient IgA, also have a place at the table for predicting treatment efficacy? We don't know. It's not been well tested or validated, and that's going to be up for further consideration. Certainly, patient-reported outcomes are of great value, but where to put them in terms of the approval process and the utilization of therapies also needs further study.